Yes, sir, we are live. Okay.
Welcome all the attendees. Myself, Dr. Anuj Maheshwari, Governor, American College of Physicians, India chapter. Welcome you all. And as you all know that we are running this month for the women's health education for the doctors as well as for the public. This is our 5th program in this month in the series of the women's health by ACP India chapter. And it is good to inform you all that this program is not only being seen by Indian chapter members, but also the members of the other chapters. Some of the chapters in US are also seeing our program. And in last few programs, good people has given their good inputs also, and people has appreciated from across the borders. So it is really a proud privilege for India chapter that this thing is becoming popular across the world, and women's health is becoming an issue everywhere together with India. As we all know that women's health is always associated with multiple endocrinological problems and multiple endocrinological diseases, and some are the physiological issues related to the endocrinology. That's why this particular issue has been dedicated completely to the endocrinological disorders. And for running this program, as a moderator, we have chosen a very dynamic endocrinologist, Dr. Supratik Bhattacharya from Calcutta. And very much important, this has been in our mind when we have designed the program. Anything if we want to make success for the women's health, anything if we want to make popular about the women's health, or we can create the women's health awareness, without participation of the males, it is not 100% successful. It is important that males should develop a mindset that female health is not only a purview of the females, and it is also to be taken into the similar way and similar importance as they take the health of males across the world. And I am very much happy to share this in last program, which we have done on the mental health and well-being of the female doctors. Many female doctors from United States as well as other parts of the world has appreciated, saying that they are also facing the similar issues in their countries. So we Indians are not the alone in facing these challenges and these issues which are coming up in the female health. And I must say that I am here with one of the very important doctor who has inspired me towards the women's health issues, and that is Dr. Minal Mohit. Minal Mohit has first spoken on this topic in 2018 Lucknow conference, Lucknow annual conference. At that time, I first realized that these issues are really very much undermined, and these are not really taken so well as they should have been. And I'm very happy Dr. Minal could be able to join this program, and I hope that she will be doing justice with the topic, whatever has been assigned to her. Dr. Swati Srivastava is very well known advisory council member to all of us, and previous programs she has already run and also spoken in some programs. So it's not really needed now to introduce her in the formal way through me. Dr. Soumita Mandal, the first time I am meeting her, and I hope that she will become a part of our ACP forum in future also. After today's talk, we shall be inviting her again and again, and her name has been suggested by Dr. Divya Saxena. So with these luminary people, those who are with us as a faculty today, I will hand over the proceedings to the Supratik Bhattacharya for taking the issues forward. But before that, I will request Harshit to play the video, what he wants to play. Over to Harshit. So now over to Supratik. You take over.
Thank you so much, sir, for this kind opportunity, and a warm welcome to all of you who has joined today. We have three prolific speakers today, and they'll be talking on three different aspects of women health. As you had just seen the topics. First on will be Dr. Minal Mohit, who would be talking about the pubertal issues, followed by Dr. Swati Srivastava, and she would be talking about hypo and hypothyroidism. And also we will have Dr. Soumita Mondol will be talking about the PCOS and obesity. So once again, congratulations to Professor Anuj Maheshwari, sir, for choosing these particular topics, which is very pertinent and relevant to our daily practices. And also to Dr. Divya Saxena, who is heading the Women's Wing. So with this, I would now invite Dr. Minal Mohit to please kindly give his talk. Dr. Minal, you're muted. If you could just unmute yourself.
Thank you, Suprati, for a kind introduction. And first of all, thanks to the governor. I am really humbled by that he remembers something I spoke in Lucknow way back in 2018. Though I myself am not really very much sure of the topic I spoke some 3 years back. But sir, thank you so much that you remembered some good thing about it. And thank you, Dr. Divya, for remembering me and giving me this opportunity to talk on a topic that is really relevant, really important. It really becomes difficult to differentiate between men and women when we talk of any disease. So when I talk of puberty, I was asked specifically by Dr. Divya to keep the topic limited to pubertal issues in girls. But there will be some mentioning of the boys also because they go hand in hand. So please allow me for that. And with that, I'll request the chairpersons to Supratik to please allow me to share my screen.
Yes, please. So you can go ahead and share your screen, please.
Thank you so much, sir. So as I was talking that I will be keeping this topic confined to pubertal issues in girls, I have been allotted some 20 minutes and the topic will cover both the aspects of pubertal issues, the two major aspects, that is the precocity and the delayed puberty. So first of all, the word puberty itself has been derived from a Latin word pubertas, which means coming to the age of manhood. That means it's a period of human development during which physical growth as well as sexual maturation occurs. If I talk of normal puberty and the normal physiology, we would understand that gonadotropin releasing hormone coming from hypothalamus, it starts getting released around the age, a certain age, which is normally decided by the normal physiology. I will come to the ages as mentioned in the next few slides. And this GnRH goes and affects the anterior pituitary, which makes it release the gonadotropins, that is LH and FSH, in a pulsatile manner. And then these hormones go and affect the ovaries, that is the gonads. And the gonads in turn release the estrogen and the secondary sexual characters, the breast development, the pubic hair, axillary hair, and of course, the menstruation begins in a normal girl. Now, this entire progression happens over a period of some 2 years. Before the destined time, there is another hormone that is inhibin B, which keeps the anterior pituitary under suppression. And after the pubertal setup, it is the estrogen which causes a negative feedback effect on the pituitary as well as the hypothalamus. So this is a normal puberty or the normal physiology. So normal physiology begins with the hypothalamic release of gonadotropin releasing hormone, which goes and affects the anterior pituitary, from where comes the gonadotropins, that is LH and FSH, and the gonadotropins make the gonads release the sex steroids. So that is a normal puberty among girls. Just before proceeding further, making few terms very clear, when we use the term pubarchy, we are specifically mentioning the development of pubic hair. The term thelarchy is defined the development of breast buds. There are cases where we find very small babies presenting with breast developments. The breast enlargement is just what we call the pseudo-puberty, or you can say they are just the effect of maternal estrogens, that there are some breast buds below 2 years of age. Then the term gonadarchy is used for the development of the gonads. And because I'm not talking about boys, so in women, we can't see the development of ovaries. So we assess women by thelarchy and the growth acceleration. Then there is something called adrenarchy because of the sex steroids being released from the adrenals. That is the development of zona reticularis. We have the adrenal androgens released. So there is a rise in the levels of DIA and DIAs. Then, of course, the final term, that is the menarche, where the menstruation begins. So these are the few common terms that we talk of in relation to puberty. The normal sequence of development in a pubertal girl is the first sign is thelarchy. And as you can see, the first sign somewhere becomes relevant around 8 years of age. And the period of thelarchy lasts from 8 to 13 years. In between, there is also puberty setting in after thelarchy, and within a period of 2 to 3 years of progression from the first point of thelarchy to menarche, the total time taken for the pubertal development is some 2 to 3 years. So, pubertal staging for girls, when we are doing, we look for the breast staging and the pubic hair staging. Breast staging, the pre-pubertal girls are always at a stage of B1, P1, that is no breast tissue development and no pubic hair. So they are all at A1, P1, and P1. This is how we stage the Tanner's staging. Tanner's staging was named after James Tanner, who gave this pubertal staging or the SMR staging, that is the sexual maturity rating, which we call it as. So pre-pubertal girls are all A1, B1, and P1. That is no axillary hair, no pubic hair, no breast tissue development. Once the puberty sets in, there is development of breast buds, that is B2 stage. When there's a definite mound, we call it B3. Adult breast development stage, the final full mound development, that is the B5 staging. And correlating is the pubic hair development. So this is how we assess the Tanner's staging in girls, that is the breast development and the pubic hair development. Now, one important feature where I cannot miss boys, actually, sorry, but the important feature is the growth velocity. And you will find that the height spurt or the growth spurt comes just before puberty. So the pre-pubertal growth spurt is a little earlier in girls, a little late in boys, a little more intense in boys. And that is why the final height, as you can see, that the same, though we are sharing the same set of parents, though sharing the same set of genes, still the boys slightly overshoot the girls at final maturity. The final height, the boys attain a slightly taller height than the girls, the children, the siblings of the same parents. And this difference is somewhere around 6.5 centimeters. And this is because, yes, the boys mature a little later. Boys mature more intensely. The spurt is more intense in boys. So the crux is that in adulthood, men will be taller. And this is because they start their growth spurt some 2 years later. So they get some 2 years more to attain height. They have a more intense pubertal growth spurt. And so they end up being slightly taller. Now coming to the disorders, because that is what we are here to discuss today evening. It can be either early, that is puberty setting in early, or it can be puberty delayed, that is setting in late. So when it is early, we call it precocity or the precocious puberty. Anything before 8 in females, anything before 9 in males, we call it as precocity. When we talk of precocity, we often find that the girls have this more common, that is precocious puberty is more commonly come across in women or in girls, whereas delayed puberty is defined when the women do not start their breast development till 14 or do not menstruate till 15. Similarly, boys, if they do not attain their pubertal development by 15 years, the puberty does not happen by 15 years, we label it as delayed puberty. Delayed puberty is more common in boys rather than girls. And when we talk of the causes of the disorders, we'll come to that maybe later. So first we talk of precocity or the precocious puberty. Precocity, why is it important? Ultimately, the girls need to develop, they need to grow. So how does it matter if they develop a little earlier than 8 years? It does matter if they develop earlier than 8 years. First of all, yes, it is because of the psychological issues, the emotional stress, a girl who's not even ready to understand what is the difference between a girl and a boy, if that girl suddenly starts menstruating, there's a lot of stress and tension, not only for the girl, but also for the family. So emotional issues, psychological issues are one part, but besides the psychological issues, we also have more physiological concerns, because we know that once the gonadotropin release begins, once the menstruation begins, there is fusion of the epiphyseal bones. So there is fusion of the epiphyses, and there is a stumping of the linear growth. That is, the further linear growth ceases. So at whatever height the girls start menstruating, after that, they hardly grow some 1 inch, that is 2.5 centimeters. So this is very important, that though the child will be initially appearing tall, the final height will be compromised. So that is why we are concerned about precocity or the precocious puberty. When we talk of types of precocity, it can be central, that is a true precocity, or it can be peripheral or a pseudo precocity. When we are talking of central precocity, we are actually meaning that it is coming right from the hypothalamic level. That is, it is gonadotropin dependent. So it is from the gonadotropin releasing hormone, the gonadotropin levels rising, and the gonadotropin rise causing the rise in the gonadal steroids. So it is the HPG axis, that is hypothalamic pituitary gonadal axis, which is hyperactive in cases of central precocity, just like the normal physiological hyperactive, just like the normal physiological activation of the HPG axis, the CPP or the central precocity mimics the normal physiological axis hyperactivation, but the only problem is that this is happening earlier. Whereas the peripheral precocity, the gonadotropins are not involved. There is suppression of the gonadotropins. It is a gonadotropin independent feature. And this is because of either the hormones coming from the gonads or from the adrenals. So it is a peripheral precocity or a pseudo precocity. At times, it can even be exogenous. It can be medicational precocity. So why do we treat precocity? Yes, again, to be very specific, we want the girls to be tall. We all want to be tall. And besides being tall, we also want the children to be psychologically balanced. So when a child has grown up enough to understand what is a man, what is a woman, and that is the time probably that the girls need to grow into womanhood, not otherwise. And of course, another important part, we must treat the underlying cause, if any. At times, there are central masses, the pituitary masses or the hypothalamic hematomas. There are CNS tumors, actually, craniopharyngiomas, which we might come to know only once the precocity sets in. So the precocity might be just a symptom of some underlying CNS lesion or a CNS mass. So we also need to treat that. So now the causes, just to classify them quickly, we are dealing with true precocity or a central precocity. It can be idiopathic, which is more common in girls, or there can be hematomas, hypothalamic hematomas. There can be tumors adjacent to the pituitary. There can be other CNS disorders like meningitis at times. There can be palsy at times. There can be even radiations at times, though radiations are more likely to cause delayed puberties, but there can be some exceptional cases of precocity as well. Then there can be some sex steroids administered from exogenous sources. Then coming to the peripheral precocity, it can be adrenals. Most commonly, it is adrenal precocity, or it can be gonadal precocity. Then there are syndromes like McCune-Albright, which is one of the very common causes of peripheral precocity. Exaggerated adrenarche, as we were talking, that at times present just with thelarche, just with some thelarche variant, or there can be even a very rare case of isolated menarche, where the girl starts bleeding without breast development, without pubic hair, and that is a very rare case of premature menarche. So how do we differentiate between the true precocity and the peripheral precocity or the pseudo precocity? How do we really know whether to treat or not to treat? So the key lies in the detailed history and the examination, of course. So one thing very clear, when we are talking of CPP, you have to remember that the entire physiological development goes hand in hand. So the HPG axis is stimulated in a holistic, in the totality, and there will be breast development coupled with the genital development, coupled with the pubic hair development. If you come across isolated feature of puberty, you are more likely to be dealing with peripheral precocity or a pseudo precocity. Then you have to take a detailed history of the parents as well, the biological parents. Most cases of CDGP or early menarche or growth spurts, they do follow their parents. Similarly, you have to have a look for the neurofibromas or the cafe au lait patches. Then there are CNS disorders. You have to consider even the smelling capabilities, the anosmia, the history of CNS disorders, central irradiations. Then coming to the examination, you have to match plot the growth, the velocity, the growth velocity, the total, the height of the child, the height of the parents, the mid-parental height you have to plot. You must calculate, then you have to see the growth velocity, the pattern, which curve the child is following. Is he jumping the heights or is he dropping the heights? Like this, the growth curves are very important here. Then the bone age is very important. The bone age, we are using the GP scale, the Grolic Piley's Atlas we are using. We can use the Tanner Whitehouse scales also, but I'm using GP scales, actually, the GP Atlas. So that is giving us the bone age advancement. If the bone age is really advanced by more than 1 year, then it is significant and it is CPP more likely. Then the breast development, if it is above the breast, the B2 stage, that is, if there's just a breast bud, maybe we are dealing with isolated thelarchy. But if the areola mound has also developed, then probably we are dealing with CPP. Then, of course, you can also have a look at the fundus. We have to look for the optic gliomas, the pressure, because most of the pituitary lesion, because of the proximity to the chiasma, we find the pressure, the pituitary masses causing pressure over the optic chiasma. So there is most likely a papilloedema, which is very common in the fundus. Then skin examination, of course, for the neurofibromatosis or the cafe au lait patches, as in cases of the McCune-Albright syndrome. Now, for example, a girl of 8 years is presenting to you with a 6-month history of breast development, along with some mood labilities. She's always been tall. You find that you track her, incidentally, her growth chart is complete, and you find that she's always been tall. She has been growing particularly fast recently. You take a detailed family history and you find mother and the sisters also experienced menarche at 11 years. Now, in such a case, you find that the girl is having a breast development of B2 stage, but no other feature, and the fundus is also normal. So probably 8-year-old girl with a 6 months history of B2 stage of breast development, growing tall always, recently growing more fast, you are probably dealing with central precocity or a true precocity. Similarly, if a girl is coming to you just at the age of 3 years and you find pubic hair development with some aggressive behavior, probably you are more likely to deal with, but otherwise the stature, the height plotting, the MPS, the mid-parental height, everything is normal. You find there is some clitoral enlargement as well. Stage P3 pubic hair, and also you find a mass in the abdomen, the lower abdomen. So probably we are dealing with low LHFSH, so that is a case of pseudo-precocity. So plasma androgens are high, so this is a case of either adrenal precocity or a gonadal precocity with low LHFSH. So now such cases, how do we treat them? Central precocity, we just treat them if we are very sure we are dealing with CPP. After doing the cranial, the MRI, that is a brain imaging or the pituitary imaging, we find there is no mass. We go for the treatment with a GnRH analogs. So the idea is to suppress the pulsatile release of the gonadotropins, because the house might consider that there is already GnRH coming from, there's a rise in GnRH, which is responsible for CPP. And we are also giving GnRH analogs. Yes, because by giving exogenous GnRH, the long-acting GnRH depot, the 3 monthly preparations, we create a plateau of the GnRH. We avoid the pulsatile secretion of the GnRH. And so there is a subsequent suppression of gonadotropins, and there is suppression of the gonadal steroids. But the decision to treat or not to treat is dependent on the medical history, the height of the patient, the height potential of the patient and the family, the decision of the family, and of course, the physician also. For example, if a girl comes before 7, I don't think we will even think, we will just treat. But if a girl comes after 8 or 9, probably we will consider the decision of the family also and the final target height also. Then the treatment with GnRH analog will definitely improve the final height outcome. You can also couple the GnRH therapy with growth hormone therapy if you are thinking that the final height might not be attained with GnRH alone. So not only height, you will also giving time for the psychological development of the child. Before taking a decision to treat or not to treat, we have also to go for GnRH stimulation test, that is the GnRH analog stimulation test. We also go for some ultrasound, and we also go for one MRI to rule out the mass, the central mass. Just quickly go through this algorithm. For example, you come across a girl with telarchy with other pubertal signs present. Growth velocity, advanced, bone age, advanced. You go for a sonography and you find pubertal sonography is done, and also you find, and the hormonal analysis, you find raised LH, GnRH stimulation test giving you a rise in LH. Then you will find a imaging study, the CNS imaging, which gives you a mass. Probably you are dealing with organic CPP. If there is no mass, you are dealing with idiopathic CPP. If LH, FSH are on the lower side, you are dealing with probably peripheral precocity. Then we go for either the adrenal evaluation or the ovarian evaluation. But if you find isolated telarchy with no other pubertal signs, you are probably, and the child is less than 2, you are probably dealing with maternal estrogens still playing their role, or infantile premature telarchy. If the child is above 2 with no other signs, and the USG is also showing you all pre-pubertal signs, just a rise in FSH more than LH, or the FSH ratio more than LH, even in GnRH stimulation test, again, you just require a follow-up, because a rise in FSH more favors your peripheral precocity or incomplete precocity, whereas a rise in LH more supports the central precocity. Coming to the next part of the algorithm, suppose you have reached this part that you are dealing with peripheral precocity, you look for the ovarian masses, and of course there are cafe au lait spots or something positive, you are dealing with McCune-Albright syndrome. Otherwise, it can be just ovarian mass which is causing the problem. It can even be hypothyroidism at times. So this was about the precocity. I don't have much time, I believe, but then just quickly, if you allow me, I'll touch the delayed puberty, maybe at least the definitions. So delayed puberty is defined when the development does not happen by 2 SD of the mean age. To be precise, if it does not begin by 13 years in a girl or 14 years in a boy, or if it starts but does not progress by 5 years, that is a pubertal arrest has happened, then also we label it as delayed puberty or pubertal delay. For girls, lack of breast development by 13, lack of pubic hair by 14, and lack of menstruation by 15. So that is for girls, to be very specific for this evening. Classification is again, either we are dealing with functional or we are dealing with hypo. Hypo means there is failure at the hypothalamic levels, that is secondary failure. Or if there is gonadal failure, is a hypo, that is your LH, FSH are normal, but your ovaries have some problem with them. So that is a primary gonadal failure, is a hypergonadotropin hypogonadism, or a secondary failure is a hypogonadotropic hypogonadism. Again, a list of causes, because my time is not allowing me. Evaluation becomes almost the same. History, physical examination. This is important. If you can give me 1 minute here. We must calculate the mid-parental height, which goes by the formula. Add the parent's height, divide by 2. For girls, subtract 6.5. For boys, add 6.5. And then, of course, there is a normal physiological range of -6 to +6. So this is mid-parental height. You have to calculate always in all children you are evaluating for height or for puberty or for whatever reasons. For girls, if delayed puberty, one important thing is you must go for a karyotyping, because Turner syndrome is a very common cause of delayed puberty. Another algorithm to deal with delayed puberty, not to confuse you, a girl coming to you with short stature, you have to do a height plotting, mid-parental height. Either it will be a familial short stature, or it will be a CDGP, or it will be a Turner's. So you have to look for karyotyping, you have to look for mid-parental height, you have to look for bone age. Then most important cause is if there is a rise in weight, then hypothyroidism is a very important cause of delayed puberty. Cushing's with raised weight is another very important cause of delayed puberty. Pituitary masses are important causes of delayed puberty. So for delayed puberty evaluation, you have to look for certain specific things. For example, I look at a 12-year-old girl who has stage 3 of breast development, stage 3 of pubertal development, with a pubic hair development. FSH level is 20. And she gives me a history of whole body irradiation at the age of 10 years. It is very clear I'm dealing with a hypergonadotropic hypogonadism. So it is a case of peripheral delayed puberty or a primary gonadal failure. So how do I manage a case of physiological, if it is a case of delayed puberty, which is just a physiological delay, then counseling and reassurance and a close follow-up is recommended. If it is a impaired gonadal axis development, then yes, we have to begin with estrogen replacement. And once we see the signs of estrogenization complete, we add the progesterone. And once the girl starts shedding the endometrium, we can keep her on OCPs or HRT till we plan her marriage and we plan her child. So that is a very quick run through for the delayed puberty. I have taken 5 minutes extra, so sorry for that. Dr. Supratik, over to you.
Thank you, Dr. Minal, for a terrific topic that has been selected for you, and you did complete justice to whatever has been given to you. So with that, I request you to kindly stay back so that we can have a good panel discussion at the end. And I'd ask all our viewers to note down your questions so that we can address them at a later time. So with this, now can we sort of request Dr. Swati Srivastava for her talk, please?
Yeah, thank you very much, Dr. Supratik. Thank you, Minal, for a wonderful talk on pubertal issues. At the outset, I'll just first share my screen. At the outset, I would like to thank Governor Acp India for making this wonderful initiative of dedicating one entire month for women health. That is very important, and we have seen so many programs which are mainly dedicated and focused, and we have learned so much in the past 1 month. And it's a privilege for me to be part of these programs, and thank you very much. So I'll just start sharing my screen. Is my screen visible?
Yes, it's visible.
It's visible. Okay. Okay. So my talk today will be on hypo and hyperthyroidism, and these are very common. The hypo and thyroid disorders are one of the most common endocrine disorders that we come across. And what is more known to all of us is that the prevalence of thyroid disorders in females, in women, is much higher than that in men. So when we talk about disorders in women, especially the endocrine disorders, which the women are suffering more and they are going through more, thyroid disorders definitely becomes very important. Now, if we see that thyroid disorders in prevalence, if we see the in women, we see approximately 1 in 8 women will be affected by a thyroid condition at some point in their lives. The risk of thyroid disorders in women is around 10 times higher than that in men. So there's a very significant preponderance of these disorders to occur in women as compared to men. The question arises, why? So we know that most of the most common causes of thyroid disorders are AITD, that is the autoimmune mediated thyroid disorders. And if we talk about autoimmune thyroid disorders, most of the thyroid autoimmune disorders are more common in women. So probably that is one reason, but that is not all. And we have some other causes also for this such a drastic increase in occurrence of thyroid disorders in women. There is interplay between the thyroid hormones and the hormones that fluctuate during the menstrual cycle, especially the estrogen and the progesterone. We'll be talking about that. The thyroid hormones and the thyroid problems become more frequent in women during and after menopause, especially when when the hormone levels begin to fluctuate and reduce. So if we see, this was a study done by Lee et al. Regarding the thyroid disorders in women. And the exact prevalence, what they found was a female to male ratio of autoimmune thyroid disorders was 4 to 6 to 1. So approximately it was in their study, this was a Chinese study, and their study they found around 4 to 6 times higher prevalence of autoimmune thyroid disorders in women as compared to men. What about thyroid nodule? Yes, that is also much, much more common in women. So it was around 3 to 4 times more prevalence of thyroid nodule in females compared to males in their study. What about papillary thyroid carcinoma and malignancies? Yes, PTC is also more prevalent in women as compared to men. And what is interesting is here is that during the reproductive age group, the PTC occurrence is very high. And it reaches up approximately the highest in say around third to fourth decade, and then the occurrence starts falling, and then by the time a woman reaches the age of around 50, the prevalence becomes same. So definitely there is an impact on the hormones probably which have probably there is an impact of the hormones on the occurrence of the papillary thyroid carcinoma. So talking about thyroid cancers, if we see thyroid cancers and gender disparity, it is interesting to know that thyroid cancers are also around 2.9 times. Different studies show different data, but they are definitely more common in women than men. In this also, we see that the histological subtypes which are less aggressive, like papillary thyroid carcinoma and follicular thyroid carcinoma, they are more common in women as compared to men. Whereas the more aggressive histological subtypes like the medullary carcinoma and the anaplastic carcinoma have usually a similar gender distribution. So this is again a very interesting gender disparity which is seen in thyroid cancers, as we know that most of the cancers have some or the other predilection to a particular gender. And it is very common with many of the cancers, and similarly so with the thyroid cancers also. So what is the cause? Is it because of any reproductive or hormonal influence or menstrual hormonal differences which occur, or there are some specific environmental factors, or there are some common somatic genetic alterations? These all have been studied very much in detail, but the disparity is still very poorly understood. The estrogen and estrogen hormone receptor status in thyroid cancer cells have been given the maximal, role which has been shown. Otherwise, all the other aspects are still, we are not very clear as to why there is this gender disparity of cancer occurring more in women, thyroid cancers. If we talk about the occurrence of thyroid disorders in women by an increased prevalence, the effect of female gonadal hormones is definitely play a role, as we know that there are direct effects of estrogen on the thyroid tissue, contributing to the development of thyroid goiter, thyroid nodule, and cancer in women. X chromosome inactivation on thyroid gland and immune system. This has been studied very much, especially in autoimmune thyroid disease. So skewed X chromosome inactivation leading to increased occurrence of autoimmune thyroid disease has been a matter of interest, as was seen in this particular study, where they studied the female twins, and they studied the skewed X chromosome inactivation and the frequency was seen in patients with autoimmune thyroid disorders and those without autoimmune thyroid disorders. And it was found that there was a much, much higher occurrence of skewed X chromosome inactivation in patients with autoimmune thyroid disorders as to those without AITD. So probably that has some role to play. Now, puberty and menstruation, the puberty, I think we had a very excellent talk just before my talk. So as Dr. Meenal also mentioned, the thyroid disorders can play a role, especially in the occurrence of puberty, precocious puberty or delaying of puberty, more so in delaying of puberty. Thyroid hormones can have an impact on menstrual disorders. We know very much that hypothyroidism can be associated with menorrhagia. Then hyperthyroidism can be associated with oligomenorrhea, polymenorrhea. So menstrual disorders are very common, and irregular menstrual cycles, amenorrhea, can also occur. Reproduction is one very important aspect where thyroid disorders can become very important because they cause fertility problems. There are ovulation abnormalities. We have an increased occurrence of PCOS also with hypothyroidism. We have the next talk coming also with PCOS and in women, where we learn more about PCOS. Increased prolactin levels, which occurs very commonly with the hypothyroidism because the TRH, the thyrotropin releasing hormone, stimulating both the TSH as well as the prolactin, probably which causes an increased prolactin and may have an impact on preventing ovulation and have impact on fertility problems. Pregnancy. Now, pregnancy is a very important aspect of thyroid disorders, and I think I have to I would not be doing justice if I do not dwell enough upon thyroid disorders in pregnancy. So I will be discussing this in some detail. If we want to see the thyroid disorders in pregnancy, hypothyroidism in pregnancy in the Western studies showed have the prevalence of 2.5%. Overt hypothyroidism occurs in 0.3 to 0.5% of all pregnancies, whereas subclinical hypothyroidism 2 to 3%. But mind you, the Indian data, whatever we go through, show much higher prevalence to the tune of sometimes 5%, sometimes some studies even show to 8 to 10% of thyroid disorders in pregnancy. What about hyperthyroidism? Hyperthyroidism complicates around 0.2% of pregnancies, and a very important aspect, postpartum thyroiditis, a very important thyroid etiology which occurs in the postpartum period, occurs to the tune of 4% to 10% of women. Physiology of thyroid in pregnancy, we know that various changes occur. The TSH, I would go to the slide. What we see is that in the last square, which you show, if you see the HCG versus the TSH, as we know, in pregnancy, the human chorionic gonadotropin increases, especially it peaks in the first trimester and then it comes down. And because the HCG stimulates, there's a similarity in the HCG and TSH, they stimulates the TSH receptors of the thyroid, causing a negative feedback with a reduction in the TSH occurring in the first trimester and then going up. So normally also, if we see, this becomes important because we have to see the TSH levels as per the trimesters. And what do we see? We see that the lowest TSH levels occur in the first trimester, and then in the second and third trimester, it gradually goes up. So we should have the trimester specific TSH ranges when we talk about hypothyroidism, especially in pregnancy, and the thyroid values in pregnancy. Now, as the TSH goes down, the opposite is seen in the FT4. Another very important thing which occurs in the physiologically in thyroid in pregnancy is the increase in the thyroid binding globulin. We know that there is an estrogen-mediated sialization of the TBG, which leads to a reduced clearance. And what happens is the half-life of the TBG is increased. Now, what happens when the half-life of TBG is increased? There is more of thyroid binding globulin. So what happens is there is more of the bound form of thyroid hormones. So as we know, thyroid hormones remain in bound as well as free forms. Because the bound forms increases, the total thyroid hormone and the free form remains similar. So the total thyroid hormone levels which we evaluate are higher, especially in the early part of pregnancy. So we may get a high T4 levels, total T4 levels and total T3 levels, which actually may be having a normal free T3, T4 levels, and the patient may not be hyperthyroid, but mistakenly may be diagnosed as hyperthyroid if this is not taken into account. So this is what we have to be careful of. Then the placental DNase augments thyroxine metabolism. So that is again important when we talk about the thyroid hormone. There is an alteration in immune status in pregnancy. So thyroid autoimmune disorders also change. As we know, there is some amount of amelioration of autoimmunity during the pregnancy and an accentuation postpartum. So that has to be taken into consideration. Normally, the thyroid gland increases in size by 10% in iodine replete countries, more so in deficient areas, and the production of hormone also increases by 50%. The iodine metabolism also is affected. There's an increased filtration in the glomeruli, and there is an increased requirement. The WHO recommends a daily iodine requirement to be 250 micrograms per day. So this has to be taken into account. Deficiency can lead to cretinism. So hence there is a variation in the normal thyroid profile during pregnancy when compared to non-pregnant women. Also, the difference in the test values of thyroid hormone profile are in different trimesters and in different distinct groups, population groups. And that is why a population-specific thyroid and a trimester-specific thyroid ranges are what is ideal in women who are pregnant. Now, why is it so important to talk about thyroid hormones being normal during pregnancy? Is that in addition to having an impact on the obstetric outcome, we know that thyroid hormones have an impact, a deficiency has an impact on the fetal development also. So during the first trimester, the developing fetus depends totally on the mother for thyroid hormones, and a deficiency can lead to fetal or the child's psychoneurological development. Gradually, as we know that over a period of say around 16 weeks onwards, the fetus, the developing fetus begins to develop its own thyroid hormones. Exactly, we say it goes to around 20 weeks. And then till then, the fetus is dependent on the mother for the hormone. If it is not there, then there could be an impairment of childhood cognitive function. This was one a very interesting antenatal thyroid screening CATS study, which was done, in which they had tried to see if that they had evaluated in the second trimester as to what was the thyroid function, and if there was mildly impaired, if there was definite hypothyroidism, it was treated, but a mild subclinical impairment was corrected. And in one arm it was not corrected and the second arm was kept, that the blood was collected and it was checked postpartum. So the second arm, the correction was not done. So here we had these patients. It was a very huge study, and in them one arm, the mild hypothyroidism was corrected. In the second arm it was not corrected, and there was a third arm which was having a total normal thyroid hormones. And it was interesting to see what the cognitive function was at the age of 3.5 years. And what they found was that there was not a significant difference among all the three groups. The study was later on followed up when the children became of 9 years of age. And in that also, the cognitive function was not found to be very different. So this was an interesting antenatal thyroid screening program, which showed that probably we have to be careful, but then in subclinical hypothyroidism, we have to see as to the risk benefits of the correction. And the overcorrection was associated with the hyperactive syndrome being high. Now, what are the indications for screening of thyroid disease in pregnancy? Having said all this, we say that because there is we are so worried about the neurocognitive development of the child, whether we should, and the obstetric outcomes also, whether we should screen all the patients, pregnant women, for thyroid disorders. No, none of the associations are in favor of screening for thyroid disorders, and all the associations say that if there is presence of any of these risk factors, then we should go in for evaluation of thyroid disorder, thyroid test, otherwise not. So not as a routine in all patients. So if there is a history of thyroid disease, a surgery, family history of thyroid disorder, if there is thyroid antibody positive, a clinical feature suggestive of thyroid disorder, goiter, autoimmune disorders, history of preeclampsia, irradiation of neck, or iodine deficiency area, mental retardation in previous birth, any infertility, or on drugs affecting the thyroid gland. What can be the impact in maternal? There can be gestational hypertension, preeclampsia, eclampsia, placental abruption, anemia, spontaneous abortion, postpartum hemorrhage, and reduced fertility. So obstetrically, we are it becomes important to correct hypothyroidism as early and as well. And the offspring can have low birth weight, preterm birth, stillbirth, congenital abnormalities, impaired neuropsychological development. How do we manage hypothyroidism in pregnancy? Our objective should be a rapid normalization of thyroid status as early as possible. If the patient is already a known case of hypothyroidism, we should target a preconception TSH to be below 2.5. We should initiate the treatment as early as possible. However, even if the hypothyroidism is detected at later stages of pregnancy, still treatment provides better results. Levothyroxine is the drug of choice, and there's an increased dose requirement to maintain a euthyroid state. As against, as in normal individuals, we know it's to the tune of 1.4 to 1.6 micrograms per kg per day. Here, the replacement is to the tune of 2 to 2. The full replacement is in the range of 2.4 micrograms per kg per day. In patients who are already receiving thyroid replacement, dose increment by 30 to 50% of the pre-pregnancy dose is usually required, or we can say 2 doses per week extra are required. What should be our treatment targets? Our treatment targets in the first trimester should be TSH should remain less than 2.5. Do not make it less than 0.1. So 0.1 to 2.5. So when we talk about the TSH ranges trimester specific, usually in the first trimester, we try to maintain 0.1 to 2.5. The second trimester goes to 0.2 to 3, and the third trimester usually is 0.3 to 3 to 3.5. But it changes from area to area, region to region, continent to continent, and even laboratory to laboratory. So we should have ideally our trimester-specific, region-specific TSH ranges. We should check every 4 to 6 weekly, and if the patient is anti-TPO positive, now that is very important. If the patient is anti-TPO positive, there is a very high chance of this patient developing overt thyroid disorder or higher levels of TSH over the course of pregnancy. So a regular follow-up and monitoring is mandatory. Indian guidelines are similar to what I just mentioned to the international guidelines. This was just a slide which I had made as to simplify as to what we should do if we have this patient, and to alleviate the confusion which arises. So if the TSH is less than 0.1, obviously it goes into the evaluation for thyrotoxicosis. If the TSH is more than 10, I'm sorry for the everything not being visible very well. If the TSH is more than 10, it is overt thyroid hypothyroidism. You have to treat with levothyroxine. Now, the problem arises when the TSH is between 0.1 to 10. Now, in that also, if the TSH is in the upper limit range to 10. So for example, if our upper limit range is say 3.5 or 4, so if it's between 4 to 10, treatment with levothyroxine should be given. And if it is anti-TPO positive, it's mandatory. If it is negative, may be given. Now, if it is between 0.1 to 2.5, you go to the left side of the chart. If it is on the lower half of the thyroid range, no treatment is required, just review on clinical grounds. This is very obvious. Now, the problem arises when the TSH is between 2.5 to upper limit of normal range, reference range. For example, if it's between 3.5, for example. So 2.5 to 4, if we take as the upper limit, then going for anti-TPO antibodies. If the anti-TPO antibody is positive, we may consider treatment, or you may consider a regular monitoring, and in case it goes above 4, you can treat. If the anti-TPO antibody is negative, treatment is not recommended. So this is as per all the guidelines given by European Thyroid Association, the American Thyroid Association, and the ACE. Now, going on to the briefly discussing the hyperthyroidism, when a hyperthyroid becomes pregnant or we discover hyperthyroidism in pregnancy, what can be the causes? It can be Graves' disease, it can be subacute thyroiditis, brainless thyroiditis, toxic multinodular goiter, toxic adenoma, TSH-dependent thyrotoxicosis, or exogenous T3, T4 being in the excess range. So these are some causes which we see in all the patients. We may get in men, women, everyone, but there are some pregnancy-specific associations we have to be careful about, and these are important because they are pregnancy-specific. So we have to focus on the etiologies for correction rather than starting to correct the disorder, because it can be seen in hyperemesis gravidarum, in hydatidiform mole, struma overi, and SCG-induced, especially in multiple gestations, because these are some conditions where we have excess of HCG, and that leads to suppression of TSH and the stimulation of T4, and we have pregnancy-related thyrotoxicosis. Now, if there is thyrotoxicosis in pregnancy, how does it impact the mother? It can cause congestive heart failure, thyroid storm, PIH, spontaneous abortions, high rates of stillbirths, and preterm deliveries. In the offsprings, it can be associated with neonatal deaths, increase in low birth weight, neonatal hyperthyroidism, IUGR, and seizure disorders in later life. So they are very important. How do we manage thyrotoxicosis in pregnancy? Now, gestational transient thyrotoxicosis should be treated symptomatically, and the specific disorder like the hyperemesis gravidarum or the other disorders should be targeted. While treating hyperthyroidism in pregnancy, which is not pregnancy associated, but there is clear-cut hyperthyroidism, since we see that there is a significant impact on the obstetric and the fetal outcome, we have to treat it. Now, the problem here arises whether we give methimazole or propylthiouracil. Now, this treatment with drugs is the preferred choice when we are talking about pregnancy and hyperthyroidism. Radioiodine is out of question. It is not given in pregnancy. Actually, a woman who takes radioiodine should not get pregnant for around 6 to 12 months at least following the radioactive iodine treatment. What about surgery? If the patient opts for surgery, the second trimester is most recommended. However, the oral anti-thyroid medications are the preferred route of management of thyrotoxicosis in pregnancy. What about methimazole versus propylthiouracil? This is a debate which is going on since long. And in the previous years, it was found that methimazole and its precursor carbimazole was found to have severe congenital abnormalities being associated in the developing fetus, like choanal atresia, esophageal atresia were found to be, aplasia cutis also were found to be much higher with methimazole as compared to propylthiouracil. So then it was thought that propylthiouracil probably is safer. But then it was found that propylthiouracil was associated with significant, very important adverse effect of hepatotoxicity in the mother. So then again, it was considered that we have to see whether we have to save the mother and of the hepatotoxicity and give the mother methimazole, or we have to save the developing child of the congenital defects and give the mother propylthiouracil. And so what was the balance between them was, which was decided, was that in the first trimester, begin with propylthyracil, and then second trimester onwards, shift to methimazole. One thing we have to be careful is that we have to give the smallest possible dose of antithyroid drugs and keep the FT4 in the high normal range. Why do we do this? So that we want to avoid hypothyroidism in the neonate.
Dr. Swati, can we ask you
I'll
to wrap up?
I'll just go through. I'm going to the last part, just 1 minute more. So postpartum thyroiditis, again, as I told you, was another important issue that has to be, there is an exacerbation in the postpartum period of all autoimmune disorders, and more so, and similarly occurs in thyroid disorders. Also, it has to be treated symptomatically. There is initially thyrotoxicosis followed by hypothyroidism, eventually normalization. Sometimes hypothyroidism may persist. Now, having seen this very important pregnancy and associated, I dwelled so much upon pregnancy and thyroid disorders because I thought that that's a very important aspect and has to be discussed. Going further now to menopause and thyroid disorders, just 2 slides for that. Thyroid disorders can increase the chances of early menopause. And there are some symptoms of hyperthyroidism and menopause which are similar and may be mistaken as early menopause, and thyroid disorders may be overlooked, like hot flashes and decreased sleep and insomnia and excessive irritability. So there is a much overlap which can be seen amongst the symptoms of thyroid disorders and menopause. Another very important aspect is that if we correct the thyroid disorders, probably we would be alleviating the woman of so many problems that she would be having she might be considering as menopause or perimenopause. What happens in perimenopause and menopause is that hormone fluctuations are very common, and there is a theory that probably the fluctuation in estrogen levels may increase the inflammation, creating the ideal environment for development of autoimmune disorders and hypothyroidism. Now, menopause and hypothyroidism also share many symptoms. So other than hyperthyroidism, even hypothyroidism, there are various symptoms which are common, like an alteration in the menstrual cycle length, the change in the amount of bleeding, the sleep disruption, mood swings, forgetfulness, fatigue, weight gain, dry skin, hair loss. So a patient may consider that she is having probably menopausal symptoms, whereas it may be hypothyroidism. We know that an over replacement can also have similar symptoms of menopause, so that also has to be taken into consideration. And undertreated thyroid disorder, now this becomes important, causes an abnormal lipid metabolism and more of atherosclerosis, cardiac impacts. So we have to be careful that we are treating correctly the thyroid disorders, and we know that thyroid disorders increase with age, and so does the cardiac disorders. So a correction would be very useful. At the same time, an over-treatment may increase the risk of the woman to osteoporosis. Again, we have to be careful that when a patient is on thyroid treatment and she undergoes menopause, the change in the estrogen levels may cause some amount of change in the requirement of levothyroxine. So a reduction may occur post-menopause. If the patient goes on any hormone therapy, there might be a necessitation of increase in the hormone levels, which might be required. So I think concluding the talk, in all the phases of thyroid, in all the phases of a woman's life, thyroid disorders become very important. So we have to be very careful when we treat and do enough. And if we do that, then we will not have any problems. I think I might have exceeded by 5 minutes. I'm apologetic for that. Thank you.
Thank you so much. Once again, I think you have covered the topic very elaborately, and that leaves very little room for questions. Now, may I please request Dr. Soumita to give her speech, please?
To Pratik sir, and to congratulate our Swati ma'am and Meenal ma'am for their excellent, wonderful, and elaborative talks. So, are my slides visible?
It's perfectly visible.
So a very good evening to all. First of all, I want to congratulate Dr. Divya ma'am and all other organizer Acp Indian chapter for arranging such excellent CMEs on women health. And I take immense pleasure to be a part of this. And thank you, Divya ma'am, for this opportunity. So I will be discussing on PCOS and obesity. We all know about PCOS, and we know their clinical manifestation, management, everything. But today I'll be talking about it from a different perspective, that is PCOS and obesity, their long-term consequences and management. So let's first recap some known facts. Polycystic ovary syndrome is a condition characterized by hyperandrogenism and chronic oligoanovulation, and it brings along with reproductive dysfunction and, of course, metabolic dysfunction. It is one of the commonest endocrinopathy, which affects around 6 to 10% of the reproductive age group women. So far, we have been using three main diagnostic criteria for diagnosing PCOS. Number one is NIH 1990, which includes menstrual irregularity and hyperandrogenism. Rotterdam 2003 criteria includes 2 out of 3, chronic oligoanovulation, hyperandrogenism, and PCOS morphology revealed in ultrasonography. And in 2006, Androgen Access Society published that hyperandrogenism should be the mandatory criteria, along with one of the 2 criteria should be there. Those are chronic oligoanovulation and PCOS morphology. So before we diagnose PCOS, we must exclude some certain secondary causes. Those are thyroid dysfunction, hyperprolactinemia, non-classic congenital adrenal hyperplasia, adrenal or ovarian tumors, Cushing syndrome, acromegaly, etc. So how PCOS is linked with obesity? We get to see a lot of women with PCOS are either overweight or obese, and different percentage have been quoted in different studies, and it ranges between 38 to 88%. Another meta-analysis showed that women with obesity has an increased likelihood, almost 3 times increased likelihood for the development of PCOS compared to their non-obese counterparts. A large cohort, Northern Finland Bard cohort in 1966, also showed a significant association between BMI and features of PCOS across all ages of life. Now, we are all aware of the fact that obese women are at increased risk for developing PCOS. But can PCOS per se lead to weight gain? Well, there are certain mechanisms which can contribute toward further weight gain and can even hamper the efforts to lose weight. It is mainly because due to androgen excess, which is a characteristic feature of PCOS. Excess androgens are responsible for android kind of obesity, for which they lead to deposition of fats in the upper parts of the body. As a result, there is increased fat accumulation in the upper part of the body, mostly central adiposity. They also cause adipocyte hypertrophy and have been found to lead to reduced insulin sensitivity. Now, this is a schematic diagram which links obesity to PCOS. We know that in obesity, there are a number of adipokines are released from the adipose tissue, and those adipokines, except adipokine and few others, mostly harmful. Those are resistin, visfatin, tumor necrosis factor alpha, interleukin-6, etc. And all of these cause an inflammatory milieu in the body, which can lead to development of insulin resistance. And insulin resistance, at one hand, can lead to metabolic dysfunction. On the other hand, because of compensatory hyperinsulinemia, can lead to ovarian androgen production. And this is mainly due to stimulation of the steroidogenic enzyme. And as a result, there is manifestation of the PCOS. Now, there are certain factors like mental and emotional health or genetic factors which are implicated both in the development of obesity and PCOS. So certainly there has been a paradigm shift in the understanding of the disease, that it is not a mere ovarian dysfunction, rather a multisystemic multifactorial aberration with far greater metabolic consequences. So what are the metabolic disorders associated with obesity? Those are impaired fasting glucose, impaired glucose tolerance, type 2 DM, gestational diabetes mellitus, dyslipidemia, mostly increased triglyceride and reduced HDL, arterial hypertension, hypercoagulation, hyperuricemia, non-alcoholic fatty liver disease, obstructive sleep apnea, and so on. So let's have a look at them one by one. First is IGT, diabetes, and GDM. It has been seen that women with PCOS, even with baseline normoglycemia, have an increased risk for developing IGT, and which almost 60% women can convert to IGT per year. And those who have IGT at baseline have a 2% risk for progression to over type 2 DM, and this risk can increase by 6 years, even up to 54%. Another meta-analysis also showed that patients with PCOS have an increased risk for gestational diabetes as well. So coming to the most dreadful complication, that is PCOS and cardiovascular disease. One meta-analysis demonstrated that women with PCOS, the risk of coronary artery disease and stroke is double, especially the risk of non-fatal stroke. And even after adjusting for BMI, the risk remains high. It is around 55%. And if it is associated with metabolic syndrome, then there is more increased chance of developing coronary heart disease and increased risk of mortality. So all women with PCOS should be assessed for cardiovascular risk factors and lifetime cardiovascular disease CVD risk by the available CVD risk calculators. And if they have certain risk factors, they should be at risk for developing of future cardiovascular disease. Coming to obstructive sleep apnea and PCOS, obstructive sleep apnea have been found in increased prevalence in patients with PCOS than in BMI and age-adjusted control women. Longitudinal data showed that PCOS have increased likelihood, almost more than 2 times risk for developing OSA compared to the women without PCOS, irrespective of BMI or age. So this is mainly because of altered hormonal profile in obstructive sleep apnea, because reduced progesterone because of anovulation and excess androgen both have a negative impact on the upper airway, which can lead to floppiness of the upper airway muscles, and as a result there can be symptoms of OSA. So regular OSA screening is recommended for women with PCOS, and treatment is offered in the form of CPAP therapy. If patients doesn't improve with CPAP, bariatric surgery is the excellent treatment option, but of course in selected patients only. Now coming to non-alcoholic fatty liver disease, we know that obese PCOS women have insulin resistance and hyperandrogenemia. Both lead to increased lipolysis. As a result, there is increased non-esterified fatty acids in the circulation, which get accumulated in the liver, resulting in hepatic steatosis. And if left untreated, they can progress to NASH, NAFLD, or even cirrhosis. So regular monitoring by LFT is mandated in patients obese PCOS women. Elevated transaminase levels are the most common and often the only lab abnormality in patients with NAFLD. Imaging modalities are quite useful. CT, MRI are quantitative and semi-quantitative or qualitative imagings. If you want to quantitate or measure the triglyceride content of the liver accurately, we can go for ultra high field MR spectroscopy. Coming to cancer risk, we all know that risk of endometrial cancer is manifold higher among patients with PCOS because of unopposed action of estrogen on endometrium. So health professionals should have a lower threshold for investigation of endometrial cancer. So they should be offered subjected for transvaginal sonography or endometrial biopsy, especially in patients with persistent thickened endometrium or having prolonged history of amenorrhea, abnormal vaginal bleeding, or excess weight. Routine ultrasound screening is not recommended, but a pragmatic approach is to add CSCP or progesterone therapy if the patient is having a cycle length more than 90 days. For other cancers, there is no strong association between PCOS and ovarian or breast cancer. But of course, if metabolic syndrome is associated, there may be increased risk for developing pancreatic CA, postmenopausal breast CA, and colorectal cancers. Now, emotional well-being is probably the most neglected aspect of management. So prevalent, and it is quite common that patients of PCOS suffer from various emotional problems: depression, anxiety, eating disorders, sexual dysfunction, poor self-esteem, sense of poor body image, and as a whole, they have a poor quality of life. And this association has been found sometimes independent of BMI. So we should be very vigilant and ask about symptoms at every visit. Anxiety and depressive symptoms should be routinely screened in all adolescents and women with PCOS with the help of some tools like patient health questionnaire or generalized anxiety disorder scales. And if required, they may be referred to a counselor or a psychologist. Now, coming to management, as PCOS comes with multiple risk factors, we should monitor these risk factors at a regular interval. For obesity, it has been recommended that we should measure weight, BMI, and especially waist circumference at every visit. Regarding cigarette smoking, it's advised that we should ask for a detailed history for current or history of smoking status, and they should be advised to quit it as early as possible. For blood pressure, those who have a BMI less than 25, we can measure it annually, but patients having a BMI more than 25, patients having a BMI less than 25, annual blood pressure checking is adequate. But for patients having a BMI more than 25, we should measure it at every visit. The target is to keep at minimum, and we should go for pharmacotherapy when it is beyond 140 by 90. In between 120 by 80 to 140 by 90, we should stress upon on lifestyle management. Regarding lipid profile, we should do it at baseline. If it is normal, then we can repeat it at every 2 years. Otherwise, if the patient is having dyslipidemia, we should repeat it annually. Oral glucose tolerance should be done at for all women at baseline, then every 2 years in absence of other risk factors. But in presence of any risk factor like family history of diabetes or history of GDM or any high risk ethnicity like Asians, we should repeat it annually. Now, lifestyle management is the mainstay of management in patients with PCOS, and we have to make it clear to the patients that there is no established cure for PCOS, and lifestyle changes is the only effective and proven method which has demonstrated substantial improvement in the symptoms. So the patient should aim to lose a 5 to 10% of body weight, and weight loss have been found to show not only to reduce total and visceral fat, but also normalizing the menstrual cycles and improving the fertility rate and insulin sensitivity. So patients should engage themselves in exercise for at least 150 minutes per week, and which should include 90 minutes of moderate intensity aerobic activity and 3 sessions of resistance exercise per week. Regarding diet, we should advise patients that they should limit the carbohydrate to 40% of total calorie intake, and for fat, they 25 to 30% may come from total calorie, and saturated fat should be limited to less than 7 to 10%. They should be encouraged to take omega-3 fatty acids. For proteins, lean protein with low fat content like chicken, meat, fish, yogurts are encouraged, and they should be advised for regular intake of fiber, around 25 to 30 grams per day. Now coming to the medical management, first is insulin sensitizers. ASHRAE 2018 guidelines recommend metformin can be added on top of lifestyle in women with PCOS for treatment of weight, hormonal and metabolic abnormalities, especially when the patient has a BMI more than 25 kg per meter square and patient is having dysglycemia in the form of impaired glucose tolerance or over type 2 DM. For thiazolidine GIOS, there are only few studies. Short-term proglitazone 400 mg daily have been found to improve insulin sensitivity and ovulatory rate, but there is no clinical studies regarding new thiazolidine GIOS like rosiglitazone or pioglitazone in PCOS. Now, inositol is one upcoming molecule, and they have insulin mimetic properties, especially myoinositol and D-chiroinositol. They are being used in the clinical practice. They are involved in the downstream signaling pathway after activation of the insulin receptors, and preliminary data suggests that they can improve a patient's metabolic profile. Though ASHRAE 2018 guidelines do not support current use in clinical practice and has considered it as an experimental therapy in PCOS. Now coming to the anti-obesity drugs, when patients fail to achieve the target weight or fail to lose any weight after lifestyle therapy or intervention for a period of 3 to 6 months, we can go for anti-obesity treatment. And orlistat is commonly used. Earlier, sibutramine and rimonabant used to be, would be used, but now they are withdrawn from the market because of safety issues, though the current androgen access society do not recommend for any anti-obesity medication in patients with PCOS because they do not improve the metabolic parameters. For GLP-1 receptor analogs, we know that exenatide and liraglutide both are approved as anti-obesity agents, but data regarding their use in PCOS-related metabolic syndrome is limited. Though they can reduce the BMI significantly, but cannot result in improvement in the metabolic parameters like fasting insulin levels or insulin resistance. And last but not the least, bariatric surgery is the last resort for all women, especially in morbidly obese women who fail all those above pharmacotherapy. Coming to statins, we can use statins those who have dyslipidemia. For PCOS women having dyslipidemia, we need to set target lipid values for LDL and non-HDL. PCOS women without any as such risk or with 1 or 2 risk factors like obesity or hypertension, we should set the target for LDL in below 130 and non-HDL below 160. But if they're associated, they have associated metabolic syndrome, then they are considered at high risk for CVD. Then the LDL target becomes 100 and non-HDL target 130. And if the patient has already established vascular disease or renal disease, then the targets are more strict. LDL below 70 and non-HDL target less than 100. But routine clinical use of statins are not recommended, especially in reproductive age group women where patient can conceive. So effective contraceptions are advised to follow. So to summarize, obese women with PCOS are characterized by a different hormonal milieu, and the main difference is severe hyperinsulinemia, insulin resistance, and lower sex hormone binding globulin. Multiple metabolic diseases, including cardiovascular diseases, are increasingly being associated with PCOS, primarily driven by hyperinsulinemia and insulin resistance. Patients' concern and age of presentation should be priority during management, and lifestyle interventions remains the cornerstone of management for prevention and treatment of such complications. So that's all. Thank you for listening.
Thank you again, Dr. Somita, for a very nice and elaborate talk on this particular topic. I understand all of these three topics are standalone topics, and it's very difficult to complete that entirely in, say, 20 or 25 minutes given time. So may I please now have all the panelists on board so that we just have about time for like a question to each of you. So we'll go in the same order as we had the presentation. So first to Dr. Minal Mohit, if you're there.
Yes, Supratik, I am here.
Perfect. Okay, so I think the first question, you have actually talked about all the algorithms, and we have seen nicely what is the management protocol and how long a doctor should wait before initiating a treatment. But I think I'll go in a very practical aspect. So when a mother comes to the doctor, they have a few questions to ask. So they ask what is the best treatment possible, and when should the treatment begin, and how long will it last? And so this is for both precocious as well as delayed puberty. And what would be your answer?
Yeah, thank you, Supratik. That was a very relevant question, actually. Yes, all parents have the most important concern is what is the future of my child? If the child is having a precocity and you are trying to stop the pubertal progression, is it going to harm the future? Will she be able to resume the progression of puberty once you stop the treatment? Similarly, in case of delayed puberty, when we start the treatment, the important question is, how soon will she start menstruating? And will she be able to conceive? Being a girl, she has to attain her womanhood, she has to attain her motherhood. So in the Indian context and in the Indian society, probably marriage, motherhood are the end all of being a woman. So yes, these are very relevant questions and both have a very relevant answer. In terms of precocity, when we arrest the pubertal progression by administering GnRH analogs, we are not harming the child or the future puberty at all. The moment, the day you stop the injections or you stop the treatment, within next 3 months, if it's a long acting, after the last dose, of course, the 3 months, the action will last. But after that, the puberty sets in again and the normal progression begins, and it will again progress for the next 1.5 year, whatever the time, the natural time, wherever if we stopped it, it will pick up from there. So there is no worries, no concerns that about the future progression of the precocity. Similarly, in the delayed puberty, when we start estrogenizing, we add the progesterone, the girl starts menstruating, it will be a variable time, of course, depending upon the cause of delayed puberty. If it is a Turner's, because most commonly it is Turner's in women, that they present with short stature or they present with delayed puberty. In such cases, the time period will vary, of course, but once they have attained their estrogenization and they start menstruating, they will continue their cycles on OCPs. And pregnancy will again come with assisted pregnancy. It will be an assisted pregnancy. So that will be again a planned treatment, which will vary entirely. The topic will differ. So we have to counsel the parents, reassure the parents that the things will be going forward in a very normal course of the way, but they will require our assistance here and there.
Perfect. Thank you so much. So now going to Dr. Swati, I think you again have covered the entire topic very elaboratively, although it was very challenging to cover both the hyper as well as hypothyroid in one particular talk. But I just want to go in the direction that, like we have clear evidence that if you're treating subclinical hypothyroidism in, say, elderly females, you have clear data to treat subclinical hypothyroid anyone less than 70 years age. But if somebody is more than 70 years, we don't have a very clear guideline because it doesn't seem to do much good. So what is your take? Because we have the guidelines to guide us, but you as a clinician, because many times incidentally they will come with a high TSH, a woman aged 75, and would come and ask you that should I be worried at this point?
Yeah, thank you very much, Dr. Supratik. That's a very important question because when we see the management of subclinical hypothyroidism, that by itself is a very huge topic, and it can be discussed elaborately, very much so. But when to treat and when not to treat. So, if we see how the TSH behaves throughout the life of a woman, so basically, as a person, not only a woman, as in generally, as we age, our TSH range also somewhat goes up, and it is allowed, it is permitted to remain. So we need not treat a TSH which is probably not very high in an elderly because of the obvious reasons that we take into consideration the cardiac status and the changes which will occur when once the thyroxine will be started. The increased metabolism that will occur probably may not be that useful as compared to the adverse impact it may have on the heart and the other things. And an over treatment may also predispose to osteoporosis. Yes, we have to treat if there is an overt hypothyroidism so that we have a very good impact on the entire body as well as the cardiac outcomes. But then a subclinical hypothyroidism in an elderly has to be taken with a pinch of salt because we have to weigh the risk benefit ratios, and accordingly we have to decide if there is any indication like the patient is symptomatic, has an abnormal hypertriglyceridemia or some such other cause where we need to treat. Otherwise, and also when we treat our target TSH levels, as we all know very well, in the elderly is higher. The target TSH also, we tend to maintain a higher target TSH in elderly as compared to the younger individuals. So yes, I agree to you that a lot of work has been done in this field, and subclinical hypothyroidism in an elderly may not essentially be treated unless required for some particular reason.
Perfect. Yeah. So I think we need to understand the set point keeps going up as you grow older, and then it's a clinical call based on whether you have symptoms and whether you can do justice in terms of cardioprotection. So thank you for your inputs. And now going to Dr. Shaumita, I want to ask you about, you had been, when it comes to polycystic ovarian syndrome, we usually have in mind that it's going to be some individual who is overweight or obese, but we are also aware of the lean PCOS. And with the upcoming managements that we have in place, we are talking about the newer therapies in terms of treating polycystic ovarian disease, addressing mainly the insulin resistance in particular. So in that scenario, what is your take on the lean PCOS? One, and secondly, on the new therapies.
Well, for lean PCOS is always becomes very challenging to treat the patients because we cannot ask them for weight reductions. But for all practical purpose, we always get to see the patient has some kind of central obesity. Even if the BMI is normal, they have. So we should focus on reducing the central obesity so that even if the subclinical level of insulin resistance is there, even if the fasting insulin level is not that high, we are not getting biochemically high fasting insulin, we can reduce those insulin level to a minimum so that this androgen excess is not there. This is one way. And second is we can all go for hormonal therapy as we do in other cases when we do not we cannot treat them only with lifestyle intervention. But then again, it is not curative, we have to emphasize it. And for other newer therapies, I think I have mentioned regarding myoinositols and all. So for endocrinologist perspective, I would say it should be kept at experimental level for now because the data are not that robust. Even if they are thought to be involved in the post-signaling pathway, but how much they are improving, actually, the pathogenesis is not clear. So all the authoritative guidelines do not recommend, and even as far as my knowledge goes, endocrinologists do not intend to use such agents in clinical practice. So I would like to know from other
So I think Dr.
panelists
Minal
as well.
wants to give a quick input. So Dr. Minal, your input, please.
This is regarding the PCOS, the lean PCOS you are talking about, Supratik? Or are you?
Yeah, you wanted to give your input regarding the lean PCOS as well as are you intending to speak on the neotherapies as well?
See, as of the lean PCOS are concerned, yes, I agree with Soumita that though they are not overweight or obese, but there is a component of insulin resistance probably at the ovarian level. So at that point of time, we do not target weight loss alone, but we do target the insulin resistance. And clinically, I don't know how much Soumita has experimented or experienced, but we do add pioglitazone at times in place of metformin as insulin sensitizers, and they also have shown good results. Anti-androgens, yes, of course, we are adding aldactone or spironolactone to most of our patients of PCOS. And of course, if we do have most of the PCOS also having some borderline rise of the 17-OHP. So we do add some OCPs maybe at times, or we do add some flutamide also. So anti-androgens do play a role, and of course, the OCPs do play a role, and even we can use pioglitazone as insulin sensitizers in a lean PCOS.
So I just wanted to come in at this point of time because we have limited data, or in fact, we don't have a data to use pioglitazone in non-diabetic individuals and who are below 18 years. So any one of you take this, I think Dr. Minal was busy. So are you happy to use pioglitazone based on the experimental results that we have in an adolescent patient or a pubertal patient? So any of you, Dr. Soumita can take the question. Or Dr.
Sorry, I missed it.
So we were saying about pioglitazone. So we don't have a clear sort of indication of using pioglitazone on anyone less than 18 years. So are you happy to use that for your adolescent patients?
Yeah, I don't think so. We do have very limited data with pioglitazone. That is very true in PCOS because most of the PCOS women have been most of them been overweight or obese. A lean PCOS study, if you look into, you will find enough data that we have used pioglitazone as insulin sensitizers even in the adolescent girls, because any PCOS will come to you or clinical practice only after 14, 15. So it's not actually a very small child that we are trying a molecule. We are administering to somebody, a girl above 14 or 15, and we don't have any clear contraindications for that. And it has been of some, like the data are there. We have been using it. And even the literature supports using pioglitazone as insulin sensitizers.
Okay. Any inputs from Dr. Soumita or Dr. Swati before we close?
In my opinion, actually, for adolescents, first of all, we have to make sure it's it's a short PCOS only, because most of them will have an ovulatory cycles in the initial phase of menstruations after menarche, like for initial 2 or 3 years. So after confirming that yes, it's a PCOS, by seeing the ovarian volume, not going for the ovarian follicle or their numbers in ultrasonography. So we first have to emphasize on the lifestyle. If at all indicated any insulin sensitizer, I would recommend metformin only. And because sometimes they have insulin resistance, of course, along with that, sometimes they have dysglycemia as well. So to address that, metformin, in my opinion, is a more preferable agent rather than pioglitazone. Even in type 2 DM nowadays, pioglitazone is gradually waning off from our practice. So probably I would go for metformin rather than pioglitazone.
Thank you. Last words from Dr. Swati before we close.
Scenario, we are not discussing type 2 DM, and even in type 2 DM, pioglitazone is not a waning of drug, we do use pioglitazone.
I think we can have a debate on this particular subject. It's a
Do
very
use
nice
it.
thing that
If
you open.
pioglitazone is coming back, let's not get into that political debate about pioglitazone status and who and why was it banned and the urinary bladder cancers and all. But yes, as Samita is very right, we initially after menarche for the first 2 years, we don't even consider PCOS. So once we consider PCOS, then that part of that age bar of your 18, before 18, after 18 does not stand much. And using a molecule as insulin sensitizer, even for that matter, if I say even metformin does not play alone any role in PCOS, it has to be combined with many other molecules as we are talking. So alone metformin hardly answers anything anywhere. It has to be coupled with some molecule everywhere, even in diabetes for that matter.
So,
that's
so
okay.
the clear question to Dr. Swati now, are you going to stick to the guidelines or can you be experimental and use your clinical judgment while it comes to treating your patients with PCO?
Okay, I think I would go a little with Dr. Soumyata, that lifestyle modification in PCOS is one thing which is the central most important thing, especially in obese PCOS, and in lean PCOS also it has a role. It has a definite role. Metformin and minoxidil both have shown very good results. So I would go with that.
Perfect. Thank you so much, all of you, for your contributions. I think we had a
Supratik sir, I would like to know your inputs as well.
So I'll reserve because today is all about you, and we will sort of have another discussion. We're running very short in time, but thank you for all your contributions, and we had a great session. Back to our governor, Professor Dr. Anuj Maheshwari sir, to close the session, and Dr. Divya.
So Pratik, before you end up, there is a question in the chat box from our governor himself.
Okay.
Do you want me to answer it or?
Yes, please, you can answer it.
So
yes, please.
Our honorable governor, he has put up a question that what extent you think that the genetics influence pubertal issues and what are the environmental factors that affect the pubertal issues? So, sir, that is very right. When we talk of specifically the constitutional delay in growth and puberty, CDGP, there comes a very, very important role of the genetics because most of such cases are familial. Either of the parents will show CDGP character. And otherwise also, even if we don't go by CDGP, otherwise also you will find that even if we don't consider the delay or precocity, just a normal pubertal development, even if we consider, you will find mostly the sons follow the fathers and the daughters follow the pattern of the mothers. So genetics do play a very important role. The second part of your question, the environmental triggers, again, the obesity plays a very important role in precocity. Why the precocity is becoming more prevalent in nowadays is again because of the change in the lifestyle pattern. With more of the obesity, more of acanthosis, more of insulin resistance, more of the impairment of your metabolism is responsible for advanced bone age because the puberty follows the bone age. Not the chronological age, not the height age. Puberty actually follows more of the bone age. And bone age is advanced with obesity. So more of the obesity, more advanced is the bone age. So the bone age is advanced, so the physiology takes up that. The GnRH spur takes up the bone age. So that is, environment is playing a very important role in precocity. That's all.
Thank you, Dr. Meenal, for a very nice answer of the question. And one thing I would like to mention it here, so Pratik, if there is any controversy arises between the two speakers, it is a job of moderator to resolve that. And final comment should be of you on whatever the question has been raised and whatever the controversy has been arising. So you must give your idea before I take up this for the final concluding remark, and Dr. Divya introduce the next program. So, please.
Yeah, so I think, okay, I can hear myself. So the clear idea is guidelines are there to guide you, of course, but we have got very, very limited data in the adolescent individuals to use anything other than metformin and lifestyle, and I'd stick by that. I would be experimental at times, but that'd be off records, and that would be a discussion for some other time. Let's see.
And
thank you. Please.
Dr. Meenal, endocrine disruptors also being quite important when it comes to precocious puberty in the environmental factors these days.
Yeah, we know that Dr. Minal is quite innovative with his ideas, and most of the time she remains far ahead than time. So maybe in the future we will be seeing that what she is saying that is right. So we must wait for some time. So with these words, I definitely enjoyed and liked today's discussion by all the three speakers. And in fact, whole of the month today was the sixth program, and one more program is still left with us. So 7 programs on women health in 1 month. So definitely we try to touch each and every aspect of the endocrinological hormonal journey of the women's health from in one or another program somehow. And apart from this endocrinological hormonal journey, we try to touch the cardiovascular issues, we try to touch the hypertension, we try to touch the, although everything is related to the hormonal issues somewhere or other place, we also try to touch the psychosexual, and we got much of the awareness, although I can't say that everyone has been so well educated by these programs, but definitely it has raised the noise level about the women health. It has raised the people's understanding about the women's health, and that was our purpose for which we decided this program to be made. And Dr. Divya Saxena has really done the wonderful job that she has constituted whole of the idea and suggested me to go ahead with these ideas, and definitely speakers has done their job very well. And definitely Supratik, we shall also be using you also in future programs. So
Thank you.
you are a very versatile speaker, and I must not leave the opportunity to keep you in one of program as a speaker. And definitely Dr. Swati Srivastava has also done the justice with the topic, although she little bit exceeded, but she has taken up the issue very nicely. And previous program also she has done very good moderation. First time I have been introduced with Dr. Samita Mandal. She is a very good endocrinologist, it seems, and we shall be getting her as a speaker in many more programs in future also. With these words, I will request Dr. Divya Saxena to please place the formal vote of thanks and introduce our next program, what is going to be held on the 31st.
First of all, thank you. First of all, I must thank you for your kind words and for your words of wisdom as well for the whole program and for the whole month. Whatever we have done with full enthusiasm and with all of our efforts, and I hope all of you must have benefited with all the discussions which were done and all the CMEs. And thank you all these speakers for the wonderful insights given in such a wonderful subjects related to women health. And thank you, Supratik, for excellent moderation of the whole program. And in next Facebook Live program on 31st August, we are again going to discuss an important subject related to women health, that is psychosocial disorders in women. And for that, we have two eminent speakers from India, in different parts of India. One is a psychologist and another is a very famous gynecologist. So we are going to discuss the subject from both perspectives, psychologist as well as gynecologist perspective. So I would request you all to join again at 8 p.m. on 23rd August, on 31st August for another important subject related to women health. So till then, thank you, bye-bye, and take good care.
Before we sign off, I just want to remind all of you, we have the annual conference of ACP coming up on 11th and 12th of December, and we want your wholehearted participation, and we are looking forward to seeing all of you there. So, thank you so much.
And also you suggest what would you like to listen in that conference so that we can put it up to the expectations of the attendees as well as our speakers.
Bye. Have a good night. Good night, Didi.